Hey, I'm Hypermobile, and if you're listening to this, I'm guessing you might be too. Hi, my name is Alex, and I'm your Hypermobile host. And today we are talking all about a highly requested topic that I've put off talking about for way too long. We're talking about hypermobility and pregnancy, folks. So, hypermobility and pregnancy, you know it's going to be complex. And for this reason, I want to stress, as always, that this is not medical advice in any way, shape, or form. If you have a health issue that you're concerned about, regardless of whether it relates to pregnancy or not, please be sure to speak with your medical doctor. As well, I do want to stress that hypermobility is a very sensitive subject, right? There are some people who have phobias of pregnancy and other things like that. So if you're not feeling this episode, if this is not something you're feeling up for today or maybe up for ever, please, there are plenty of other amazing things out there you can go listen to, including previous episodes of the Help I'm Hypermobile podcast. And if you're someone who's feeling alone in all this, you want a super awesome community that you could be a part of, I do want to just give a shout out to the Hypermobility HQ private membership. It's a private membership run by yours truly. And we have weekly lives, guest speakers. We did a special event last week. It was just a few days ago, actually, which was absolutely brilliant. If that interests you, check in the show notes. It's pretty awesome. Anyways, moving on, let's get straight into today's episode. Hypermobility and pregnancy. It's complicated. If you're looking, before we go any further too, I do want to say, please check the show notes seriously for this episode. There are some great resources out there. The British Journal of Midwifery is an awesome resource. They have the best clinical summary that I've ever seen on pregnancy, at least online, in my opinion. So please go read that. If you're someone who's getting pregnant, like that's the one thing. If I had to pick one thing for you to read, it is that article. You will find it like very clearly marked in the show notes. Okay. That is my one like best piece of advice. As well, though, of course, there's the Ehlers-Danlos Society, and there's also Heads Together, HEDS Together. So regardless of whether or not you have a diagnosis, because as we know, a diagnosis is a privilege, and many people with HEDS do not have an HEDS diagnosis at the time of getting pregnant or ever in some cases. That's a great resource regardless of your diagnosis status. So please go check it out. But now my thoughts, because that's probably what you came here for. So the structure of today's show, I went back and forth, on this, right? Because there's a lot of ways that we could have talked about this. We could have looked at it by body system. We could have looked at it by like kind of progression of the pregnancy and stages. But what I'm going to do is pretend like I'm sitting down with my best friend, or if I had a sister, like just sitting down, and I'm going to give you a heart to heart on what I think are the single most important like topics that you understand if you're hypermobile and you either are pregnant or you're thinking of getting pregnant. So topic one, things can go well. Okay. So I know online, especially in social media, we see a lot of negative experiences, and these experiences do happen. Scary things happen. There is an increased risk of some very scary things like hemorrhage, for example, which scares me. But we also have people who have fairly unremarkable pregnancies. If we use my mom for an example, again, someone who was never diagnosed, but she loved being pregnant. She felt her best when she was pregnant. And we do know that a certain percentage of hypermobile people actually get on really well with pregnancy. But the reality is that some people do not get on well with pregnancy. Some people might be okay during the pregnancy and horrible in the postpartum and the rest of their lives potentially. And some people, the whole thing sucks massively. Okay. So we have to create space and create room for everyone's experience. Okay. So if you're a hypermobile person and you had a great pregnancy and you're feeling good now, like hats off to you. That's awesome. And if you're a hypermobile person who is really, really worried about everything, and maybe your mom had a bad pregnancy and went on to have a lot of health issues later, then you're welcome here too. Okay. Everyone's experience is welcome. And we do really see that spectrum. This is the problem with all the hypermobility stuff. We see a mixture of experience, which is what makes it so confusing. Now, the example that I think of is like rolling a die. So if we're going to roll a die, so there are 6 surfaces, numbers 1 through 6. Again, this is not based on any statistics. Okay. So do not try and say that I'm making up statistics here. But let's pretend like for a person who has no health issues at all and they get pregnant, that the chances of something bad happening are like a 1 out of 6. So if they roll number 1, 2, 3, 4, 5, like all good, and number 6 is going to be like something bad happens. For a hypermobile person, I think the risk of, it's not that I think, it's that the research does suggest that the risk of some things happening which are problematic is higher. But it doesn't mean that no matter like what you roll on the die, that you're going to necessarily have a bad outcome. Some people will have good outcomes. Some people some people will have those worse outcomes. So to go back to that die analogy, I think of the hypermobile person, instead of just having like number 6 mean a bad outcome, they might have numbers like 5 and 6 mean a bad outcome, or 4, 5, 6, or whatever, right? There's just an increased risk of problems. That's all that means. Um, Again, there's controversy throughout this entire podcast. Just if you hear me say anything, just imagine that someone else is being like, it's controversial, because it's all a bit controversial and the research is mixed and there's not enough of it. But when it comes to pregnancy classification in HEDS, again, based on statistics from America and in America, there are certain issues, of course, with the healthcare system and with specifically obstetrics and labor and delivery related health concerns and procedures and outcomes. It is classified as a high risk pregnancy. But whether HEDS and HSD are going to be classified as a high-risk pregnancy really depends on the country that you're from, and whether or not it will actually be a high-risk pregnancy in terms of you as an individual depends on that individual's symptom presentation. And this is why I love the British Journal of Midwifery, because they really make that very clear. It does depend on the individual. However, what frustrated me a bit in my research and in what I was looking at is how often there's this talk of like, assemble your team of healthcare providers, because how is anyone supposed to get a team of healthcare providers, including like an anesthesiologist and a cardiologist and all these other things, when you don't even have a diagnosis, right? So I feel like there's a deep conflict between the advice, which is online from some really high quality sources, with the realities of what it's like to actually be a hypermobile patient. So on that note, we're going to start to focus on things that are more in your control, or things that you can do, even potentially without a diagnosis, okay? And we're going to start at the very beginning. We're going to start, maybe you're someone in your 20s and you're thinking of having a child in a few years or whatever. We're going to talk preconception. So I think that pregnancy really needs to be appreciated for the extremely physically challenging, I'm losing my words, psychologically challenging, and just like complex event that it is. If I was someone like pre-pregnancy thinking about all this stuff, I would be wanting to make sure that a few things were in order. Firstly, I would want some blood work done. I'd like to know my vitamin D levels, maybe my B vitamin levels. We know that quite a few hypermobile people seem to have issues with folate in particular. That's benign. I think it's sensible to speak with your medical doctor about maybe taking a version of folate called methylated folate, simply because there is some research that suggests that there are some people who are hypermobile who have issues actually metabolizing and absorbing the folate that they take. So they might be taking a regular like folic acid supplement, but just because they're taking it doesn't mean it's going in. And because folate affects the development of something called the notochord, so it affects what goes on to be the baby's neurological system long term, and it happens so early in the whole development, the whole pregnancy is happening very, very, very early. For that reason, I would want to make sure that I had my B vitamin levels checked, and that I was taking a supplement that was appropriate for me. And as far as I know, there are no drawbacks to taking a methylated folate supplement, because all that's happened there is that a methyl group has been added to the folic acid, which just means that if you're someone whose body struggles to do that, it's already been done for you. It's like buying, I buy chopped frozen onions because I'm tired and I don't want to chop onions. It's kind of just like having that step taken care of. And the price difference is there, but it's not significant. So I think it's something that if more people were aware of, they would probably want to do. So speak to your medical doctor about that. As well, I would be wanting to be in the best physical health possible. And this is hard. This is so hard with HEDS and HSD and undiagnosed symptomatic hypermobility. But I would want to make sure that my muscles and joints were feeling as good as they could possibly be. So if that meant trying to find a physio who I felt comfortable with, or osteopath or chiropractor or whatever, if that meant maybe trying to do some safe and strategic exercise, maybe even some strength building, if you have the time scale for that, like you're a year or 2 years out from pregnancy, that's the type of thing I would really be wanting to focus on, okay, and doing that safely. Because the more physically well you can get pre-pregnancy, the better able your body is to accommodate the stress, like the stressful event of being pregnant. So I would want to do prehab. That's what we call it in like the physio land, right? I'd want to do prehab for the pregnancy. Let's normalize prehab for pregnancy in HEDS and HSD, but that's what I'd be doing. As well, I would want to kind of assess, look at my options and think about my situation. I would be wanting to think about, okay, is getting pregnant the right choice for me? There are different ways that people can live their lives. Not having children is a very valid choice and something that I think we are going to keep seeing more people consider just because I think we're kind of like the first generation where it's becoming semi-normalized to some extent. But I would want to say, how can I understand what's really involved with pregnancy and with being a parent? And this is something I've thought carefully about. You have to think of resources in terms of community or family. So let's say that something did happen during pregnancy or during postpartum or whatever. Do you have a support network of like family or really close friends or someone who can help care for your baby? What's your situation with your partner or partners or whatever? Like, do you have anyone available to you to help out? Or are you going to be on your own? Because that changes things quite a bit. I think it's also important to think in terms of financial resources. So let's say, for example, you're someone, you don't have a lot of family and you don't have, like a close community network, but maybe you can afford to have some type of like a nanny assistance in those early days. That will make a difference. Let's say you're someone living in, I think it's the Netherlands. Is it the Netherlands? I can't remember. But let's say you live in a country where they have really good postpartum support services. I think it's the Netherlands, where you get like 8 days of someone just living in your house, helping with laundry and cooking and cleaning and baby stuff. That might like impact, how things go. So look at your life and see like, what support do I have? And that's something which I think not enough people consider. It's something which can be changed in some instances. Is something which maybe moving to a different city can affect it, or planning your life around it, or just, taking a moment to check in with what's accessible to you. And it's something which might help you make the decision that's right for you. And it's not a fun discussion, but I think it's an important discussion to have. Additionally, I think it's extremely important to think of the possibility of what if something happens down the line. So something I see in the patients I work with is there will be patients who have more pronounced presentations of symptoms, right? There are patients who rely on mobility aids and who will have, who will not be able to work a regular schedule, for example. And there are some patients who kind of are able to work a regular schedule and have a more minimal presentation, or are able to better cope with those symptoms, or have maybe more support networks and so on. And I think it's really important to understand with this stuff that you can be someone who identifies as well, or you can be someone who is relatively well, and then something can happen in your life, heaven forbid, like an infection or whatnot, right? And that can be the thing which kind of makes you less well than you have been. So if you're someone out there listening to this being like, you know what, I got it. I have all my good physio. I have my whatever, all my supports in place. I'm doing great. It's just always so important to remember that feeling really good now doesn't necessarily mean feeling great in 5 years or 10 years or 20 years or however long. We have to be a parent for life, but I hear that I hear that most of the work is in the first 20 years or so. I don't have any children myself, by the way. I'm just a cat mom. Anyways, in terms of other things pre-pregnancy, I'm a big fan of people improving their cardiovascular fitness. I think it makes a huge difference in terms of dysautonomia. So dysautonomia refers to dysfunction of something called the autonomic nervous system. It controls your blood pressure and your heart rate, and it controls your digestion and so on, right? If you want to read more about steady state training, I do have an exercise guide on it. Again, I'm not saying necessarily it's safe for you. Please speak with your medical doctor if needed, but you can find that in the show notes as well. And the reason for this, of course, is that we have changes in blood volume and the demands and stresses placed on the cardiovascular system during pregnancy. In terms of one last preconception thing, We need to think about potentially issues with conceiving. So, here we're coming to a place where the research is quite mixed again, but it seems like there is some research to suggest that hypermobile people might have issues with getting pregnant. Again, hopefully, more research will be done on this in future to give us a more conclusive answer. But my gut feeling, based on what I see in my patients, is that this is likely due to undiagnosed polycystic ovarian syndrome. So, polycystic ovarian syndrome is a condition where the person who's ovulating is not ovulating at regular intervals or not able to ovulate reliably or at all in some cases. They have signs and features of what's called hirsutism. So, they're like growing hair on different parts of their bodies. They're having a lot of things go on. It's a whole thing. We'll do a PCOS episode. I've actually kind of done an episode on it. I did one on period issues. So, you might want to go check that out. Anyways, I think that probably quite a few of the people who are having issues conceiving are people who are having issues with undiagnosed PCOS. So if you're someone in that category, look up the diagnostic criteria, speak with your healthcare provider, and make sure that these things aren't being missed. Something that I'm a fan of as someone who I was told I was too skinny to have PCOS, by the way, which is weird because weight is nowhere in the diagnostic criteria. And I've had 185-day long cycles. But anyways, something that I would recommend doing and that I do personally is called the symptothermal method. This will only work if you're not on hormonal birth control, but it's where you basically track your cycle very, very closely using basal body temperature and cervical fluid readings. And this is a cool way to improve your body literacy. You get to learn, like, am I ovulating? When am I ovulating? How long is my luteal phase? A short luteal phase can be a reason that people really struggle to maintain a pregnancy. So it will give you a wealth of information. If you have time and wish to learn about it, I'll put a resource in the show notes. Again, this is going to be a long show notes, but I will put a resource in there for you. It's a 12-page PDF, which kind of outlines all the rules. I'll try and find a couple studies. Again, this method, when it comes to identifying ovulation, is extremely accurate. It's accurate like 90% plus, I think 95% plus in terms of identifying the ovulation and whether or not it's happened and the fertile window plus or minus 3 days. So this is something which may be for you. I know it's certainly for me, but just because something's for me doesn't mean it's for you. Now, I think we covered everything pre-pregnancy. Let's talk about pregnancy. So, when it comes to pregnancy, I think it's really important to appreciate that HEDS certainly, and research suggests that HSD also, although there is a little bit of controversy here because we can't have anything hypermobility related without controversy. But these are autosomal dominant conditions. And with HEDS for certain, we can say that it is inherited in an autosomal dominant pattern. What does this mean? Autosomal simply means that the gene is not located on the sex chromosome. So you have a certain number of chromosomes in your body, and there are some that are particularly for sex, like the X and Y ones. It's not on those ones, okay? It's on one of the other ones. That's all autosomal means. Dominant means that if one parent has the gene and their child, they reproduce with someone else and they have a child, it means that there's a 50% chance that the child will have that condition. Because if you have one copy of the gene, so you get one gene from from one parent and you get one gene from the other, if you have that gene, you will have the condition, and there's a 50% chance that you will get that gene because the affected parent will have two genes, if that makes sense. So anyways, that is, in summary, a very brief explanation of HEDS genetic inheritance. Now, where this gets complicated is we don't know what gene or genes cause HEDS. There is research that's emerging. It's very, very exciting. But at the time of filming and recording this, we do not know what gene or genes cause HEDS. So in summary, I think the point that people get confused about is that we can, through studies, identify the inheritance pattern of a condition. It's what Mendel did with peas back in the day. You know, are the peas like, I don't know, yellow color or green color or whatever? And it's what we've done with HEDS. There have been studies that look at the inheritance patterns of HEDS, which have found that it's autosomal dominant, but we do not know the exact genes. And because of this, it means that you cannot have screening for HEDS and HSD. It is not an option. Now, whether or not you should is an entirely different subject for an entirely different episode in the distant, distant future when we feel like doing a super, super complex and controversial topic. But there's no genetic screening. If that's something you were curious about, it does not exist. And I do want to also say there are a lot of hypermobile people who are awesome and who very much like being here. So even if that existed, it might not be something which you would want to do. And that's all I'm going to say on that for right now. Anyways, moving on. When it comes to pregnancy itself, there are some people who will get pregnant, physically, like in their body, like the kind of old fashioned way, if we call it that. But there's, of course, also things like surrogacy or other ways of getting pregnant. Again, there are ethical issues with that. There's so many ethical issues with pregnancy. This is why I was up all night stressing about this episode, okay? But there is a world of options that you should talk with your medical doctor about if you are concerned. But let's say that you're someone who is getting pregnant yourself. What do you need to think about? Well, we need to think about a few things. Firstly, we want to think about the mechanical stressors on the body. So babies have weight. There's like the placenta, which is a whole thing in and of itself. There's changes in the mother's, her musculoskeletal system. There are hormones like relaxin, which make the tissue a bit stretchier. So there's a lot going on from a musculoskeletal and a mechanical perspective. The most common issues which I've seen in my patients are things like pelvic girdle pain. So issues with the pubic symphysis, which is a little joint right in the front of your pelvis, way down low. There are also issues with things like hip pain and hip issues and hip dislocations or subluxations, and also with knee issues as well. I see a lot of knee pain too. Carpal tunnel syndrome is another big one. And we're seeing issues because that connective tissue is becoming more stretchy throughout the pregnancy. That relaxin is affecting it. And there are other hormones as well. But to keep it simple, we're just going to talk about relaxin. There's also the weight of that baby and the position. And that is changing the mother's posture. It's changing how like the load her body has to cope with. It's a lot to carry a child physically, just in terms of literally just like carrying it physically. Like that's a lot of stress. As well, we start to see changes in terms of some of the organs that the developing fetus puts pressure on. So the bladder is a big one. Of course, a lot of hypermobile people have issues with incontinence. People report kind of having peed themselves a little bit, like even as children or as teens, because the bladder is a sac of connective tissue with a tube of connective tissue that leads to the exit, right? So we have a connective tissue situation, which we're then putting a baby on top of, which is going to put different stressors on it. We also, of course, have issues with things like reflux. So a lot of people who had gastroesophageal reflux disease pre-pregnancy, they're going to start to have worsening symptoms potentially. We also have issues, of course, with things like morning sickness, as it's called, and in cases which are severe, hyperemesis gravidarum. For those of you who don't know, hyperemesis gravidarum, or HG, is a condition where the mother is unable to keep food down and basically vomiting profusely. And that is something which can be very problematic, especially in someone who's hypermobile, not even just from a nutritional perspective, but also from a musculoskeletal perspective. This is something I couldn't really find any research on online, but I know that being sick, like throwing up, it makes my ribs hurt. And my expectation is that it would make hypermobile mother with HG, it would make her ribs hurt too. So we have a lot of different considerations there. As well, of course, we have to think about the dysautonomia. So we mentioned it before. One of the more common, or should I say more well-known now forms of dysautonomia is POTS. So that's postural orthostatic tachycardia syndrome. There are other kinds of orthostatic intolerance too, like orthostatic hypotension. But there are people who are going to have issues with their cardiovascular system. We then put a baby in there and their blood volume increases. And the cool thing is actually for people with POTS, research does seem to suggest that it's going to be a bit of a benefit in some ways, because they're just going to have a greater blood volume, which is going to help things function a bit better for a period of time until, of course, they give birth, and then that changes everything. But that doesn't mean that there are people with POTS who are going to necessarily feel better. There are people who feel worse. So again, it's a very, very mixed bag. That being said, the change in blood volume means that we need to think about that cardiovascular system. Something which you certainly might want to speak with your medical doctor about, I know I would be wearing compression socks from like day one. There is an increase in things like varicose veins in different places in the lower extremity and throughout the body. And I know that I would be wanting to give that external support to my body should I get pregnant. So whereas some moms might wait till later along in the pregnancy to add in compression stockings, I think that for someone who's hypermobile, it can certainly make sense to make these interventions earlier and more precisely. So speak with your medical doctor about that. In terms of other things as well, I think it's really important to consider talking about issues early. The sooner you identify issues and the sooner you speak with people about them, the more options you have theoretically. So when we get, we've kind of let's pretend like we've got through pregnancy. I haven't really touched on increased risks of bleeding throughout pregnancy and increased risks of potentially cervix issues and so on, but those do happen, okay? And I'll try and put them in a blog post. But when we get to to labor and delivery itself, okay? We need to make sure that that patient ideally has thought about what they want and has spoken with people beforehand. Now, I know there are some people out there who are just going to be like, you know what? I don't want to even think about it. I am not going to think about it. And that's cool. You do you. Okay. But if I had a friend who was hypermobile, I would be telling her, like, please speak with your medical doctor about your concerns, your wishes, things that you're worried about, and so on, right? So this is just like the theme of this episode. Doesn't mean you have to do it, just means it's what I think is helpful. So when it comes to labor and delivery, one thing which we all need to talk about is pain management. So if you're someone who's hypermobile, you might have noticed, and again, it's not everyone, because why would it be? That would be too easy. But you might have noticed that you have issues with local anesthetic. A great example of this is if you're at the dentist. So some hypermobile people will not respond to numbing injections at all. Some people will respond a little bit, but they need more, or they need it to be topped up more regularly. And theoretically, there's a group as well who will respond fairly normally. So if you're someone who has had issues with local anesthetic previously, and I would say just if you're someone who is hypermobile regardless, it might be worth talking with your medical team about things like epidurals and things like other forms of local anesthetic, because they won't always work. Or they won't always work in the same way in people who are hypermobile. Again, I'll try and put all my research in the show notes. But when it comes to epidurals, if it was me and I was pregnant and I was approaching, giving birth, I would want to make sure that I understood all my options and knew of options other than epidural. Because I think the person who hasn't thought about pregnancy as much as I have, perhaps, they think, oh, don't worry, if I'm in too much pain, I'll get an epidural and it will work. And it's not that simple, especially for hypermobile people. Now, I would also be wanting to think about things like nitrous oxide gas that's available to pregnant mothers in the UK. It's something, again, where right now in the UK, I don't know if you saw this in the news. I think The Guardian did an article on this, but there is a shortage of nitrous oxide because they found that on some of the hospital wards that have poor ventilation in the UK, which is more common than you would think, the midwives and other staff on those wards were breathing in too much of this nitrous oxide, or whatever they call it, like gas air, I think they call it here. Anyways, they were breathing in too much of that, and it was causing them to potentially have issues with B vitamin malabsorption and other things. So they have now stopped making available nitrous oxide in some hospitals entirely. So if that was a pain management option that a person who was going to give birth was relying on, they might be surprised to go give birth and not have that there. So it might help if you even look at the hospitals which are an option to you, or call them or try and contact them, just to know what the menu of pain management options is. And yeah, I just want to say too, the gas air, or whatever they call it here, it's a mixture basically of nitrous oxide and oxygen, and you get a little mask and the patient can self-administer it. And I think even if it doesn't obviously it doesn't provide the same level of pain relief as other interventions, it's something which can help, and which I think people, especially in the UK, where I know it is quite a common option, they go into their delivery thinking that they will have that to rely on, and to not have that there would be quite a shock. Now, in terms of other things that you might want your health team to be aware of, or whoever's helping you to give birth to this baby, you would want them to probably be aware of some of the issues surrounding episiotomy and hypermobility. So episiotomy refers to incisions that are made to help with the vaginal delivery of the baby. There are different types of episiotomies. There are some where they go kind of forward back. There are some where they go more out to the side. Based on my research, I know that I certainly would want to avoid a forward and back one. But even the ones that go out to the side, because of how they affect the thigh, can have huge problems. There is I think there was one research paper that suggested that some patients would actually have better outcomes from a C-section than an episiotomy, just simply because of the risk of prolapse long term. So this is a talk, and this is like the thing. I don't even know how this would happen, because a lot of people who are hypermobile, they don't have a diagnosis. They don't have this team. I watched this lecture this morning, and there was like this at the last slide was like, find your healthcare team and talk to them. They don't have a team. They're just getting whoever's at the hospital on the day. So I don't know how this would actually work, but what I would do maybe is bring a little like a folder with me. Like, what I would do maybe is bring a little folder with me, and I would be like, here's what I would like you to know, person who is here and helping me hopefully safely deliver my baby. But I would want them to understand that I am extremely concerned about risk of prolapse following an episiotomy because of hypermobile connective tissue. It basically means that wounds don't heal as well as they should sometimes. And people, even if they haven't given birth vaginally, they are at risk of having things like prolapse, which is the medical term for organs moving downwards: rectal prolapse, uterine prolapse, vaginal prolapse. Things move down when you do not want them to move down. So I would really want the person who is helping me deliver my baby to know that I'm very sensitive about my pelvic floor. On that note, going back to what we said earlier about prehab, you could also like look for some pelvic floor physiotherapy. I think that's a great thing to do. But again, it's all up to you. It's your pregnancy and your body. Now, I would also want them to be aware about moving my body around. I had a patient the other week tell me that she was lying down on her back, kind of in a reclined position on her back, giving birth to her baby. And the person who was there, the midwife, or I don't know if it was a medical doctor or whatever, they like yanked back on her leg. I would not want someone doing that to my legs. So I don't know if I'd be the favorite patient ever or the least favorite patient, but I would just want my partner there, or like I would just have a big document with me explaining like, do not aggressively move my joints. Listen to me. If I tell you something, if I tell you I'm in pain and I can feel something, it doesn't mean it's in my head. It means that the pain relief you've given me has not worked because hypermobile connective tissue people problems. So please listen to me. I think the big thing here is just patients being listened to. That's what will save lives, and that's what will make everyone's pregnancy experience better. But anyways, carrying on. I would want to think about different positions. So I'd be very aware that positions that work for other people might not work for me. I would also be aware of the fact that there's an increased risk of what's called precipitous birth, or I think it's precipitous labor actually. But basically what this means is that from the onset of contractions to baby like being born is 3 to 5 hours, which is a short window. And it can really, I think, catch a lot of healthcare professionals off guard. So knowing also that my mom had that happen with 2 pregnancies, I would want my healthcare team to know, it might look like it's going slow. It's often kind of like a slow progression of the pre-actual contraction stuff. But I would say like once we get there, it might go very, very fast. Please be aware of that. As well. It might affect things like making sure that you are prepared for a home birth. Not that I'm advocating that, but just in case it happens. And this is one of the suggestions, actually. I think I saw it in the British Journal of Midwifery, but they were saying, just having a partner or, yourself being prepared for like what a home birth might entail. It just takes away a bit of the risk, right? A prepared home birth is better than a not prepared home birth. So if you can make sure that you have some of the sterile stuff required to make sure that if you're in that situation that you could manage, that can just take one stress, one worry that you have and just decrease it. A lot of this at the end of the day is looking at risk management and potential benefit, kind of like a risk benefit analysis. And learning about a home birth is something which it's not going to hurt you and it might help you. So that's the kind of thing that I would do personally. When it comes as well to baby actually being delivered and coming out, there is an increased risk in people who are hypermobile of baby not being positioned in the right way. So we have to remember, giving birth is not just a one-person thing. It's a 2-person thing. There's the mom and the baby. And again, when I say mom, I want to just stress, I didn't say this earlier, I'm including everyone. Anyone can be a mom. I don't care like what your gender identity is, or if you don't even identify as a gender, like anyone who is giving birth, this applies to you. Okay. But the person who's giving birth, they might have the baby, which is just not cooperating. There's a 50% chance their baby is hypermobile. I don't know if studies have actually been done looking. It would be really hard to do because how do we know, like in utero, if the baby's hypermobile or not? They'd have to almost be like retrospective studies. But the baby might just not be playing ball. It might be in a really annoying position. And that might be a thing. Even if the mom is doing great, baby can cause problems. So this is why pregnancy is such a complicated and stressful thing, because it's not just a one person situation. It's a two person situation. Now, being aware that baby might be positioned not as well, I think helps patients prepare too for the reality that they might not get the birth experience that they want. They might have to have a C-section, right? Or they might not get the water birth or whatever like they were hoping for because of the baby at the end of the day. So just having that expectation management in mind. And again, all of this stuff goes back to basic things. We talked about being listened to earlier and believed. We're now going to talk about informed consent. Like literally, if people just have their risks and benefits explained to them, it's the gold standard for informed consent is called a brand statement: benefits, risks, alternatives, and nothing. So what are the benefits of giving birth vaginally? What are the risks for this patient of giving birth vaginally? What are the alternatives? Could they have a C-section or do something else? And what happens if we do nothing? You don't have a choice to do nothing when they're giving birth, but you know what I mean? Like we could just, if it's a shoulder injury, what happens if they don't have any treatment at all and we just leave them and do nothing at all, right? Like a brand statement. We just need more brand statements. That's all we need in this world. Not all, but it would be a good start. Anyways, when it comes to people actually giving birth, we talked a bit about baby positioning problems, but we also need to talk a little bit about the actual tissue down there. So there does seem to be this increased risk of precipitous labor leading to really, really fast births. But there does also seem to be, so there's an increased risk with episiotomy. So when an episiotomy is made, that incision, again, theoretically is made to help deliver baby. I think that if it was me giving birth, certainly I would want to be allowed within safe, always being safe, right? But I'd want to be allowed to give birth to that baby slowly and in a controlled way. And I would really want to have good support and coaching on like not pushing too fast and trying to avoid pelvic tears. Like other than healthy baby, healthy mom, my second biggest goal would be not tearing my pelvic floor because that would be really helpful. But yeah, episiotomies and awareness of tearing and not pushing too fast. I think that's a really, really important thing to make sure every hypermobile person is aware of. As well, when it comes to medication, both during labor and delivery and any kind of, drugs people are being given or taken or pain management, as well as throughout the pregnancy, I should have said this earlier, people need to talk to their medical doctors because they might need a medication to help manage their symptoms that maybe hasn't been studied as much as would be ideal, but we need to think of what's safe and appropriate for that patient. And again, we don't have the studies on pregnancy that we need because researchers don't like studying people who are pregnant because there's a risk, of course, of potential harm depending on how the study is structured and how it's actually carried out. So it's something that we've shied away from for way too long. There are books written on this, and it's something that hopefully is changing and hopefully will continue to change in future. But for now, it really does come down to risk management and looking at the risk-benefit ratio by that patient's medical doctor at the end of the day. Now, in terms of a C-section, I think, again, it's really important to be aware of the benefits in some instances. Here, we've had the phrase for a while, I think like breast is best. And I hate this is best, is this or worst. Whatever is best for the patient is what's best for the patient. If you're a hypermobile person and a C-section is best for you, that's cool. That's good. That's great. I'm happy you have good healthcare. If you're a hypermobile person and you feel like a vaginal birth is best for you, again, that's great. In terms of the guidance, research does suggest and guidance does suggest that unless there is a clear reason why someone with HEDS should not give birth vaginally, then that should be ideally probably the best option. But again, every single patient's different. Now, when it comes to the postpartum period, this is a very, very problematic situation because we have someone who not only has all of the chronic health issues they had before, they have them being exacerbated or them being complicated by the postpartum hormonal chaos, mechanical chaos. Like there's a sudden change in your body and the stresses of a newborn, which I don't know personally, but I've heard they don't sleep so well at the beginning and that they need to be fed very often. Anyways, you have a baby to care for theoretically if you've made it through this. If you have family members you can reach out to or friends or community or whatever, like do that. I think that a lot of hypermobile people, because they've had to struggle for so long, I think they almost hold back or they're shy to ask for help. Like ask for that help because you probably have people who care about you more than you think. So reach out. Even if it's just people like helping with some food prep or maybe helping with some cleaning. Like I think that we see a lot of kind of hyper independence part, maybe because of a neurodivergent component of all this stuff, but reach out to your support network. Even if you think you don't have one, you might be surprised as well. We see a lot of issues with dismissal of muscle and joint pain. I cannot tell you how many patients I've had see me who it's like years after their last pregnancy and they tell me, oh, I developed plantar fasciitis during the pregnancy and postpartum, but the medical doctor told me it was just normal and it would go away. And now that it's been 2 years, they say that it's chronic and I have pain just because I'm like old and now I have to live with it or whatever. That's ridiculous, right? Like we need to look at musculoskeletal injuries appropriately. We need to stop just accepting that someone who's given birth is necessarily going to have pain that is not treatable, right? We need to take these injuries really seriously. So I think that that's something I really want to emphasize is if you're someone who is looking to a pregnancy in the future and thinking about the postpartum period, or you're someone who's listening to this who is postpartum, your body still matters. Your health still matters. And ideally, you will be able to access healthcare providers who will actually help you with this. Okay. So don't live with excessive pain if you don't have to. I know that part of having HEDS and HSD is chronic pain, but we want to try and just minimize it as much as we can, right? As well, I think we really need to appreciate the psychological changes and stressors which can happen. Postpartum depression is real and scary, and there are other psychological conditions which can occur. And research does suggest, I believe, that people who have HEDS and HSD are at a greater risk of having issues like postpartum depression. So again, you might find it helpful to, if you can afford it or if you can manage it through a healthcare plan that you have, schedule things like therapy in advance. I know if I was giving birth, because I don't have my mom around, like I just get sad at the idea of it, right? So I know that I'm someone who probably would be high risk for postpartum depression, and I would be wanting the support of a mental health worker, probably maybe pre-pregnancy, certainly during the pregnancy, and absolutely after the pregnancy. So try to anticipate those issues. If you can't do it on your own, try and work with someone who can help you. But anticipating issues or vulnerabilities like that, they can help you really have positive outcomes where otherwise we might be going down a path where we start to have some negative outcomes and some harm happen to that individual. So think about you, think what you're worried about, and appreciate there might be a reason why you're worried about it and why you're stressed. As well, in terms of postpartum issues, breastfeeding, again, nothing is, as I like to say, nothing is good, nothing is bad, and everything's complicated. So if you are someone who is struggling to breastfeed, again, breastfeeding is quite a complex thing. It requires the person with the breast to be doing something, the person with the baby to be doing things and latching. There's a whole bunch of complications that can occur. There are things like tongue ties, which again, I don't think we have research on the prevalence of tongue ties in people with HEDS and HSD. I do wonder if it could be higher though, but who knows? But anyways, it's a whole thing. If you can find a magical HEDS lactation consultant specialist, please let me know. I will send them many patients, and I might see them myself one day. But when it comes to breastfeeding, it's very challenging mechanically. You want to make sure you're in the comfiest position possible. You want to make sure you're supported, prop up the tissues that you can, get all the pillows, all the supports, and try to make sure that your body's not being hurt as you feed your baby. But if you can't breastfeed, that is why we have bottle feeding. So again, find the option that's right for you. And ideally, you would certainly have that magical support team, which all of the presentations that I've seen talk about, but yet I don't hear about from most of my patients. One last thing I want to say, actually, briefly, I think, just about this whole thing. If we kind of look at what we've talked about today, is it's almost like having a plan, right? But it's not just even like a birth plan. It's like a pregnancy, birth, and postpartum plan. There's a lot of some controversy, I should say, around planning. Some people say that, like, if they saw me or if they were thinking, looking at how I think, if I told my medical doctor, like, yeah, I have like a pregnancy plan, a labor and delivery plan, a postpartum plan, they'd be like, oh, this patient's anxious, they're overthinking, they're catastrophizing. I disagree with them. I think that I'm being thoughtful and that I'm anticipating problems or concerns that I have, and that I'm really trying to find solutions and treatment strategies to those. So I think there's so much of putting patients down. And if you're someone who finds thinking about things beneficial, maybe you're someone like me who's been an overthinker your whole life, this can be a really good opportunity for you to look at and assess and identify your options and find what works for you. And if you have a medical team that's telling you, oh, you worry too much, stop stressing, blah, 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 they're probably not like the best healthcare providers. And if you can find different healthcare providers, do that. If you can't, then you just try to make it work. But I think that at the end of the day, thinking about these things can help to prevent harm. Like, for example, using a personal story, I used to be very keen on the idea of a home birth. I was like, I think they call it crunchy, but like I was back in the day, like very much that way. We're talking like a decade plus ago, right? And I used to think like, oh, I would not want to go to a hospital for a birth, right? I want to do it at home with like whatever, right? Not saying home births are bad. You can, again, there are awesome midwife support services in some parts of the UK. You do what's right for you. That's the whole point of this episode. But speaking about myself, when I learned more about, for example, the risk of things like hemorrhage, like, after the baby's been born, you have to do the whole placenta delivery thing. When I learned about how fast hemorrhage can happen and how quick and how scary and life-threatening it can be, that was something which made me say, you know what? I want to give birth in a hospital if I ever have a baby. When I learned about the fact that things like placenta accreta, which is a condition where the placenta doesn't form quite how it should, which can affect, again, we can have bleeding issues from that, which are very scary and in some instances life-threatening. When I learned about that, I was like, you know what? I definitely want to give birth in a hospital that has some facilities for these kinds of emergencies, just because for me, I couldn't stomach that risk. Some people will be more okay with stomaching that risk, but for me, I wouldn't feel safe with it. I know that I used to not want even to have an IV placed. I hate needles, and I hate the thing I hate most is IVs because they're like inside and outside the body at the same time. I do not like them. I've had surgeries. I am not a fan of IVs. But again, after reading all this and after like listening to nurses who've talked about how hard it is to place an IV when a patient is hemorrhaging and has lost a lot of fluid, you know what? I'd rather have the IV there. So it's something which the more you learn, you might be surprised how much your views change. So as always, my recommendation to you is to keep learning, to keep asking questions. I hope you've learned something from today's episode. And I hope that most of all, you feel like you're not alone in all this, because you're not alone. And I hope that one day we will have more answers and more research and more guidance. But for now, literally just finding healthcare providers and medical doctors, if possible, who will listen to you and who don't care if for some patients, I think they get so scared because they don't have a diagnosis. I like to imagine like Jen Hamilton. I don't know if you've seen her on TikTok, but she's a labor and delivery nurse. And I like to think that if I came up to Jen Hamilton and I was pregnant and going to give birth and I was like, hey, Jen, you know what? I don't have an HEDS diagnosis, but I'm hypermobile and we have all these issues and I'm a bit worried about this, this, and this. And research suggests that I might be at risk of having these issues. And there's a chance that you might have me have some pain relief intervention and it might not work on me and I might still feel pain. And I'm scared of feeling you stitch me up potentially and feeling that. Can you please just listen to me and trust me as your patient? And I like to think that someone like, if we say like Jen Hamilton would be like the ideal labor and delivery nurse, I like to think that Jen would be like, you know what, Alex, I hear you. Thanks for telling me all that. I'm going to try and incorporate that into your care because you're my patient. And of course, I hear you and I trust you and I see you and I care about you. So that's what we want. It doesn't always happen, but let's keep trying to make it happen, shall we? Anyways, hope you've enjoyed today's episode and I'll see you next time.